Thank you so much. So, my topic will be about off-label use, mix and match, and mismatch in revision. These are my disclosures. They did not change in the last 3 hours. I will refer in my presentation to this document. I consider this one of the most important documents delivered by EFORT because it was with the aim of safety for the use, safety for the patient, but also safety for the surgeons who are doing the surgery that we do, like revision. And I will show you now why. Everything started after a meeting that was in Brussels in January 2020. That was about safety and implant initiative, and was together with the European authorities, and we discussed also the topic that we discussed during the symposium about recertification and about MDR. Anyway, the scenario, the topics that we are discussing about are the problem of the current indication for use, that they have restrictions that are often based on historic indication and contraindication, the IFU that you find inside the boxes of your prosthesis. The new medical device regulation with the recertification of implant, which is a big problem, as we heard today. And then the mix and match in primary and in revision that can pose legal issues. And especially in some countries, I know that in Germany this was a big problem, surgeons can consider it as implant manufacturers when they mix and match in primary, but even in revision. And this can apply to long-lasting and well-working implants used by many years by surgeons that can be under pressure because of these legal issues, not because of the good clinical results of the patient. So this is the scenario. Let's start with the definition. What is off-label, the first of the 3 topics? Off-label is the user of whatever the label has been placed on, is using it in a way that is not listed in the IFU, the indications for use, that are cited in the label. We have a huge amount of cases with this, especially in revision. For example, this case was a failure of a revision stem that was revised with the primary stem. Most of primary stem, they have no indication for revision, but we are happy to use when we can use in revision, especially for our patients that have less invasive implants. Or you are cementing a liner from a company to another cap because you don't have the original liner, for example, in a case like this of periprosthetic fracture of an 83-year-old male, where you are not ready maybe to have the proper liner or you don't have on the market. So you are cementing a new liner. This is an off-label use of a liner which was not done for being cemented. Or you are cementing a dual mobility. This is a failure, an infection, dislocation of a spacer, so this lady needs a dual mobility. We cemented the dual mobility there, but again, this was not the original purpose. Or another case, this is a total femur, the patient was dislocated, the cap was stable and osteointegrated, a constraint liner was cemented. Again, this is an off-label use. But we can go also to some more extreme situation where the surgeon takes the responsibility. We all know that in case of fracture of ceramic, because of ceramic or ceramic, anyway, when we have fragments on ceramic, there is a clear contraindication for the use of metal. We have heard this today. We cannot use any metal in case of fracture of ceramics. But when you have a lady like this that dislocated after 17, 18 years after surgery, because of this spine problem, the hip dislocated anteriorly with a fracture of the ceramic on ceramic, or a case like this that was revised because of ceramic fracture, so they both need the dual mobility, you cannot use a common dual mobility. So in an off-label use, we use the ceramic liner with the poly liner in dual mobility with the ceramic head. So this is, again, an off-label use in the interest of the patient. The document stated these 2 recommendations about the off-label use that was published after a consensus conference, so you can use it in your practice as a statement approved by an EFORT consensus statement. First of all, there may be indication for the application of total hip implants for purpose outside the one for which the manufacturer intended, both in primary and in revision. Recommendation 2, surgeon should balance the risk and benefit to the patient, obtain informed consent, and document the decision process appropriately, which is just the description of the operation. Then let's speak about mix and match. Mix and match is the use of components from more than one manufacturer in completing the construct. Usually, it is done on purpose. We have a wide literature about this coming from registry. This is from the Netherlands. 11% of total heap had the mixed components with similar results compared to the others, even if the company said you cannot do this. This is the New Zealand. They confirmed that the use of unmatched components has no adverse effect on the outcome. And this is the National Joint Registry. When it is not associated with increased revision, the only situation when it was is when there was a head from one company and the stem from the other, but we know that we cannot mix match a head from one company and from the other. We will come to this later on. And interestingly, the best solution, the best total heap in the new in the NJR is the case with a stem from one company and the cap from the other when we have softened hard, ceramic on poly or metal on poly. We have cases complex that where we know that we can need a very small cap from one company and a stem from another in primary. But in revision, the progress is much more important. We have a longer session on this. The cap can be stable and well positioned. The stem can be stable and well positioned. So we have to balance pros and cons for further surgery. A case, this is a ceramic on ceramic. Everything was stable. We know that the ceramic is coming from the same manufacturer for both cases, even if the companies are different. This is a revision. The lady was already revised twice with ceramic on ceramic. On the other side, the young lady, the cap was malpositioned. This is a poly on metal on poly, not properly seated. We change the cap. We go with ceramic on ceramic, but we use a different head for the stem with the proper cone. Or some companies not producing anymore the cones or the head for this type of stem. And again, here we are mixing and match different heads. This done on purpose. You know that this is a company that produces heads for this situation, but this is for revision situation. Or all the cases that we have every day. We have to do complex reconstruction. We cannot use caps for the same brand from the same company that produces the same. So this is a clear mix match, or even in more complex situation where there are few companies producing custom-made implants, so in which we have to mix and match, for sure, even with the dual mobility, like in this case. So recommendation 5 from this document is with an unanimous consensus is when in revision, total hip or total knee, only one of the components needs revising, mix and match should be allowed, taking the patient risk-benefit balance, the available evidence and the current state of the art into account. Surgeons should be allowed to avoid replacing a component purely to avoid mix and match. Finally, mismatch. This is something different. The size or connection of components do not fit or match each other. In some way, they are incompatible. This is usually a mistake. We know, and this is, of course, very important, that we have different type of cones. And what we call 12-14, they are not all 12-14. So we must be extremely careful because it's not just the diameter, it's the length, it's the angle, it's a lot of things. So we must be careful about this. And we have where in this situation we can have true neonosis, we can have ceramic head breakage that are reported. In literature, this is a case when a surgeon mixed and matched metal on metal. You know that we cannot never use metal on metal. We don't use metal on metal anymore, but even in the past from different companies, he mixed and matched stainless steel with cobalt chrome, and in 2 years the proximal femur disappeared. Or, even worse, this guy revised this patient because of dislocation. He changed the line. The line was on metal, he changed the head. He used a head that was done just for a polyliner, so he mixed and matched metal on metal, and this was a disaster. So recommendation 6 is it is crucial for surgeons to only combine implants that are compatible. Mismatch of components where their size or connection do not fit may have catastrophic effects. It is essential that appropriate measures should be put in place to avoid component mismatch. Unanimous consensus. Finally, some general recommendation. As always, surgeons must be fully aware of the features of the component that they use off-label. They must be appropriately trained and must audit their results. So you must have a look and control your results along the time if you use something which is off-label. As mix and match is an off-label procedure, the reason should be explained to the patient and informed consent obtained, which is easy, the patient understands, especially in case of revision, that you are doing what is better for the situation. If the application of a label and mix and match follows the recommendation 1 and 8, most of the ones that I presented before, the clinical benefit of the patient, surgeon should not be considered as implant manufacturers, which has a responsibility. We are not insured to be implant manufacturers. Recommendation 11, where manufacturer, and this is a dream, have ceased regular production of an implant, they make provision for some of these legacy devices to remain available when required in revision operations. This initiative should be supported by regulators to ensure simplified recertification. And this is about the MDR, and this is why a lot of implants, a lot of heads, a lot of small pieces of the implants are disappearing, because they are not recertification anymore. And even a bigger dream is that in order to ensure safety of head taper assembly in hip arthroplasty, standardization committees and implant manufacturing industry are encouraged to develop a uniform definition, which integrates geometrical and topographical features of the taper to reduce the potential of incompatibility. What we mean in this bureaucratic language is that we would like to have a universal European code. In conclusion, mix and match as well as off-label use is extremely common. Efforts aim to deliver recommendation on this practice based on available evidence and the consensus process. Unanimous or strong consensus were achieved on appropriate and careful use of mix and match and off-label. Thank you for your attention.